I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. We usually take our digestive tracts for granted until something goes wrong. Maybe it's time for a gut check. This is the People's Pharmacy with Terry and Joe Graydon.
Ozempic, Wegovy, Mounjaro, and Zepbound are some of the hottest drugs in the pharmacy. They've been in short supply for months. How do they affect the gastrointestinal tract? Why are surgeons so concerned about these new diabetes and weight loss drugs?
Many people are fascinated with the color and texture of poop. What can it tell us about our overall health?
Are floaters or sinkers better?
Coming up on the People's Pharmacy, how digestive health influences everything from cancer to cognition.
In the People's Pharmacy Health Headlines. A few years ago, fish oil was all the rage. That enthusiasm has dropped off dramatically because carefully conducted trials didn't support all the claims. But a recent study suggests that some older people are less prone to Alzheimer's disease if they take fish oil capsules. Scientists at the Oregon Health and Science University conducted the clinical trial with 102 volunteers at least 75 years old. MRIs of the participants' brains at the start and again at the finish of the 3-year study showed fewer white matter lesions in those taking fish oil instead of soybean oil, but only for certain individuals. Those with the gene for ApoE4 that predisposes people to Alzheimer's disease got significant benefit from the fish oil supplements.
Hot dogs, bacon, and bologna have been linked to a higher risk for chronic conditions like GI cancers and heart disease. Now, scientists are adding Alzheimer's disease to the list. A study presented at the Alzheimer's Association International Conference included 130,000 nurses and health professionals who completed dietary surveys every few years for decades. People who consumed at least 1/4 serving of processed meat daily were 14% more likely to develop dementia than those who had less than a 10th serving daily. Regular processed meat consumption seemed to speed cognitive aging based on test results. But volunteers who ate legumes or nuts in place of processed meat lowered their risk of dementia by 20%. And slowed aging of their brains.
Scientists have long questioned whether people using anti-anxiety drugs such as alprazolam or diazepam might be more susceptible to dementia. A new study suggests that older people should avoid long-term use. Previous studies had offered mixed results on this topic. Older people often take these medicines to help them sleep, and more than a third take their sleep aids for many months. The Dutch investigators used data from a large study with more than 5,000 participants over 60. All had normal cognitive function at the beginning of the study in 1990, and all took regular tests every 4 years to assess their brains. Researchers used pharmacy records to tell who was taking a benzodiazepine, at what dose, and for how long. The scientists did not find that people taking benzodiazepines were more likely to develop dementia. However, they did find that those on benzos had accelerated shrinkage of 2 important brain areas, the hippocampus and the amygdala. Neuroscientists believe that these parts of the brain are important for memory and judgment. Consequently, the study authors suggest that people might want to avoid long-term use when they can.
Treatment for Parkinson's disease has not changed significantly in over 50 years. Patients have taken levodopa to help with this movement disorder since 1967. It works by boosting dopamine levels in the brain. But now Japanese scientists are exploring the role of a kind of seaweed called Eclonia cava. The antioxidant activity of the polyphenols in this plant appear to reduce neuronal damage. So far, the only research has been conducted in a mouse model of Parkinson's disease, but if the results hold up, this form of seaweed may offer a unique way to reduce the risk of developing Parkinson's and possibly even treating it.
Grandmothers across Northern Europe have long relied on vitamin D-rich cod liver oil to maintain immunity during winter months when sunlight is scarce. A new study of nearly 20,000 participants in the UK Biobank compared blood levels of vitamin D and the risk of infection among people with type 2 diabetes. The researchers report that people with low circulating levels of vitamin D, known as 25-hydroxyvitamin D, were significantly more likely to suffer infections in the lungs or digestive tract. They were also more vulnerable to sepsis. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. Americans have traditionally been less concerned about their digestive tracts than Europeans. As long as there are no obvious problems, we generally don't think about our gut health. But perhaps we're not paying enough attention.
People around the world seem to understand that a balanced microbiome is essential for overall health. Now, they didn't necessarily have a name for the microbiota, but there was a recognition that good digestion helps the brain and the heart as well as the GI tract.
Healthcare professionals have just recently realized that the gut-brain connection is two-way, not just from the brain to the digestive tract, but also from the GI tract back to the brain. What we eat really does have an impact on how we feel and think. Is there a connection between our diet and our risk for neurodegenerative diseases like Parkinson or Alzheimer's diseases?
To learn more about the gut-brain connection, we're talking with Dr. Robynne Chutkan. She's a board-certified gastroenterologist and a faculty member at Georgetown University Hospital. Dr. Chutkan is the founder of the Digestive Center for Wellness, an integrative gastroenterology practice located in Washington, D.C. She's written the digestive health books Gut Bliss, The Microbiome Solution, The Bloat Cure, and The Antiviral Gut, tackling pathogens from the inside out.
Welcome back to the People's Pharmacy, Dr. Robynne Chutkan.
Oh, it's such a pleasure to be back. Thank you so much for having me.
Dr. Chutkan, we're excited to be talking with you today about the gastrointestinal tract. And let's start with something very, very basic. Why is the health of our GI tract so integral to good health elsewhere in our bodies?
Terry, I want you to just look down and take a look at your gastrointestinal tract. And look where it's located. It is smack dab in the center of your body.
So it is.
It's literally the engine for your entire body. So all the different organs, your brain, your lungs, your heart, your immune system, your musculoskeletal system, they all rely on the nutrients that are absorbed and extracted by the gut to function. And so that's why it's so critical, because it is sort of the hub. If that hub is not healthy and isn't doing its job properly, you can't drive a car with a broken down engine. Not going to get very far.
Well, it seems to me, Dr. Chutkan, that cultures all over the world have known about this not just for decades, but for centuries, if not millennia. And if we were to go to China or India, it's part of their healthcare system. People in Germany have known about this. People pay really close attention to their digestive tracts. And yet in this country, I would say up until maybe 30 or 40 years ago, we didn't pay that much attention to it. Why has it taken us so long to catch up with the rest of the world?
Well, I think the whole concept of things like Ayurvedic medicine, natural medicine, if you think about Chinese herbal medicine, it really has been millennia. And I think we've been focused on a more pharmaceutical model in this country, the idea of, a pill for every ill. And it doesn't really matter what you're doing, what you're eating, how you're living, because you can just take a pill and get everything back on track. But when it comes to the digestive tract, that really doesn't work. You really have to pay attention to what's going on and primarily to what you are feeding your body through your digestive tract.
Well, you mentioned that the digestive tract is right there in the middle of the body, and it's feeding everything. And you mentioned the brain, and this idea of the brain and the stomach. It seems like they're worlds apart. And if you were to talk to a neurologist, they'd say, well, yeah, the brain, it doesn't really have anything to do with the stomach. Why should we care?
But what about the gut-brain axis we've been hearing about?
Absolutely. Dr. Michael Gershon, who was a researcher at Columbia when I was actually there as a medical student, talked about the second brain, the enteric nervous system, and the second brain in your gut. We have about 7 times as many nerve cells in our digestive tract as we have in our spinal cord. Now, we don't have nearly as many as we have in our central nervous system, but the gut is a very well innervated organ in the sense that it has lots of nerve cells. And we often feel that as butterflies in our stomach, nausea when we're nervous, a sense of foreboding that we feel as a heaviness in our GI tract. So we can definitely feel that. We talk about the gut instinct. It's very real. And we know that a lot of the neurotransmitters that the brain uses, things like serotonin and dopamine, are made in the gut. They are co-manufactured by gut bacteria. Serotonin, the feel-good hormone that's associated with feelings of happiness and well-being, about 70 to 80% of it is manufactured in the GI tract. And there is bidirectional communication between the gut and the brain along the vagus nerve, one of the cranial nerves. And by bidirectional, I mean that the gut is influencing things in the brain like cognition and memory and mood, and the brain is influencing activities in the gut like digestion and absorption, etc. And motility, movement of the gut. So it is a two-way street between these two organs, and they are very intimately connected.
So there is literally a connection, a nerve connection. It's a big nerve.
Yes. Yeah, a physical connection. In addition to, there are metabolites that are made in the GI tract, and some of these metabolites are very important for brain function. When things in the gut are off, when there's dysbiosis and the microbiome is affected, the gut can make inflammatory metabolites. And some of these metabolites are what we call neuroinflammatory, meaning they cause inflammation in the brain. And so they can literally cause mood disturbances, memory issues, etc., through that very direct communication.
I think people have heard now on the People's Pharmacy and from you in the past this idea of the brain-gut connection. But there's an area that seems brand new, or at least hasn't really been discussed much, and that's cancer. The idea that certain cancers might be affected by the microbiome, maybe melanoma, maybe prostate cancer, and that's where this whole idea of fecal transplants comes in. Can you kind of bring us up to speed on this brand new area of research?
Early stages of cancer often show up as dysbiosis in the gut. And then a dysbiotic microbiome, meaning an imbalanced, sort of out of whack microbiome where often there's less diversity, there's less richness, that can end up having a pro-carcinogenic effect via certain bacteria. And I give you some examples of how this can happen. The gut bacteria, when they're out of balance, can also create carcinogenic metabolites. They can cause chronic inflammation, and we know that chronic inflammation is often a precursor to cancer. They can damage DNA, and that damaged DNA in cells can lead to abnormal cell division and cancer. And they can actually activate different gene pathways that lead to cancer versus lead away from cancer. So there are multiple ways that the microbiome can affect our likelihood of developing cancer. And I want to be clear, this is not a straight line. We can't say dysbiosis equal cancer. But when we think about something like cancer, we know that this is a multifactorial disease. These are diseases that are affected by genetic predisposition as well as environmental triggers. And by environmental triggers, it's literally things in the environment, toxins, polluted air, things in the water we might be drinking. We know that diet is one of the significant environmental factors and environmental triggers that can also lead to cancer. And we think that microbial alteration is one of the ways what we're eating can lead to cancer. If you think about GI cancers like colon cancer, pancreatic, stomach, there's often association with a diet high in red meat or high in processed meats. And we know that that alters the microbiome. So the microbiome may be the intermediary through which a lot of these environmental triggers, including diet, are manifested to end up with cancer as a result.
There's another area that I think we're going to be learning a lot more about in the coming years, and that is neurodegenerative disease. I don't know very much about it, but it's my understanding that Parkinson's disease shows up first in the gut, maybe even years before you start to have neurological symptoms.
You're absolutely right, Terry.
So there's a possibility that we really should be paying attention to our gut health in order to make sure that our brain and our nervous system stays healthy as well.
Dr. Parkinson, when he first described Parkinson's disease over 100 years ago, described a cohort of patients who were extremely constipated. And he found that when they were able to relieve the constipation through changing the diet, again, this is in the 1800s, that their movement disorder, which came to become known, was named eponymously after him as Parkinson's disease, that their Parkinson's improved by treating their constipation. And it's a fascinating story. A German neuroanatomist, and this is just really in the last few decades, decided to look in the gut in some autopsy studies of Parkinson's patients, and he found these abnormal clumps of protein along the nerve endings and realized that what we call the Lewy bodies in Parkinson's, these clumps in the brain, develop first in the gut. And this is a basis for what is now known as the gut first theory of Parkinson's disease. And it's probably, we're finding with research, also applicable to autism spectrum disorders, to multiple sclerosis, to certain types of depression, to multiple neurological diseases that actually have their root in the GI tract, maybe even Alzheimer's.
Well, what about Lewy body dementia?
Yes, Lewy body dementia, those same Lewy bodies that they're describing. And we also have good evidence that Alzheimer's in certain people may begin in the gut.
You're listening to Dr. Robynne Chutkan, a board-certified gastroenterologist and faculty member at Georgetown University Hospital. She's the founder of the Digestive Center for Wellness, an integrative gastroenterology practice. Her latest book is The Antiviral Gut, Tackling Pathogens from the Inside Out.
After the break, we'll talk about medications that can disturb the normal action of the gut.
Have you wondered how medicines like Ozempic or Mounjaro affect the digestive tract?
Anesthesia guidelines have had to change because of Ozempic.
It can slow stomach emptying dramatically, so people getting ready for surgery need to stop eating much earlier before the operation.
We'll also hear about fecal transplants. When could they be useful, and what challenges might they pose?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This podcast is made possible in part by CocoVia, backed by 20 years of scientific research and the maker of the most proven and concentrated flavanol extract in the market today, Coco Pro Cocoa Extract. Cocoa flavanols are among the most studied plant-based bioactives today and are clinically proven to promote cardiovascular and brain health for the long term, supporting a strong heart and better memory.
Get 15% off your order of any CocoVia product by using the discount code PPOD15. Learn more at CocoVia, and remember that discount code is PPOD15.
These statements have not been evaluated by the Food and Drug Administration. This product is not intended to diagnose, treat, cure, or prevent any disease.
Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Grayton. The People's Pharmacy is made possible in part by CocoVia dietary supplements. CocoVia Memory Plus is formulated with 750 milligrams of cocoflavanols, a level clinically proven to improve 3 different types of memory and support brain function. More information at cocovia.com.
Today, we're exploring the role of the digestive tract for overall health. Drug companies have figured out ways to outsmart Mother Nature, or at least that's been the perception. Modern pharmaceuticals can suppress stomach acid amazingly well. But what are the implications of upsetting the acid-base balance in the GI tract?
We also have amazingly effective new weight loss drugs such as Wegovy and Zepbound. But these medications also alter the function of the stomach and intestines. What happens when the motility of the stomach is drastically reduced?
Surgeons have become concerned that the guidelines that have been established to tell people how long before surgery they should stop eating may no longer be good enough. People taking drugs like Ozempic, Mounjaro, and Wegovy may still have food in their stomachs that could make surgery more dangerous.
We're talking with Dr. Robynne Chutkan, board-certified gastroenterologist and a faculty member at Georgetown University Hospital. She's the founder of the Digestive Center for Wellness, an integrative gastroenterology practice located in Washington, D.C. Dr. Chutkan is the author of the digestive health books Gut Bliss, The Microbiome Solution, The Bloat Cure, and her most recent, The Antiviral Gut, Tackling Pathogens from the Inside Out.
Dr. Chutkan, we've been talking about the gut microbiome. We've been talking about how important it is to have a rich diversity of microbes in our lower intestines. But we don't usually think about having a lot of bacteria in the small intestines. And I think when that happens, there are problems. Can you tell us about small intestine bacterial overgrowth, or SIBO?
SIBO refers to a disrupted microbiome, but I am very cautious when I talk to people about SIBO in making sure they understand it's a form of dysbiosis, it's a form of disruption. So one of the commonest reasons why you would see more bacteria higher up in the GI tract than you should, because of course the upper GI tract is not sterile, but it's a gradient. The commonest reason is because of a disruption to the pH. We talked before about proton pump inhibitors and how they change the pH of the gut. So they convert the upper GI tract, which is normally very acidic and therefore more hostile to bacteria. They change it to an alkali pH, and that allows it to be a more hospitable place for bacteria to grow. And so proton pump inhibitor use is strongly associated with SIBO because by removing the acid, you allow more bacteria to grow. And so the solution is not to then use antibiotics to kill off the extra bacteria. The solution is to restore the pH gradient of the gut. And so I find that so many of the approaches to SIBO are the sort of quick fix. Well, we're going to just use an antibiotic and we're going to remove the extra bacteria and all will be well. But if you don't examine what the underlying reason for this disruption is, you're really not going to fix the problem, and you're going to create more problems because the antibiotic you just used to get rid of that extra bacteria in the upper GI tract is itself also killing a lot of healthy bacteria elsewhere in the GI tract, and probably going to lead to more dysbiosis. So you're sort of digging a deeper hole. So really looking at some of the factors, and it's not just acid blockers that can cause SIBO. Motility disturbances, if you're taking a medication that slows things down, that could be something
Such as, because we often go shooting right past motility drug disturbances.
Yeah.
But what would be some examples?
The most striking example would be an opiate, so narcotic type medication that really slows things down so much that it's even it creates a disease called opioid-induced constipation. And of course, there's a drug to treat that disease too, which is just kind of points out the irony of all of this. But the narcotics would be on one extreme end of the spectrum. But even vitamins containing iron can disrupt motility. Many, many drugs that we take, even common drugs, antidepressants, antihypertensives, vitamins, so many of the drugs we take on a daily basis, over-the-counter supplements, as well as prescription drugs, alter gut motility. And altered gut motility, particularly when it's slowed down, is one of the really common causes of SIBO. So we really need to do a little forensic evaluation rather than just, this is what you have, we're going to give you this medication, which, by the way, is going to cause more problems downstream and not really going to solve the problem.
Well, that really opens the door to this new category of medications that has captured the world's attention. It's made Denmark incredibly wealthy. It's, of course, the GLP-1 agonists that everybody knows as Ozempic and Wegovy, and of course there's now Mounjaro and Zepbound. These drugs do affect gastrointestinal motility to the point where surgeons and anesthesiologists have to be really careful because these medications can cause some unexpected complications. I wonder if they too might be affecting the bacterial overgrowth in the small intestines. Can you tell us a little bit about what these drugs are doing?
These drugs have a really potent effect on the GI tract. They induce delayed emptying of the stomach called gastroparesis, which translates to stomach paralysis. It doesn't mean the stomach is actually paralyzed, but it can slow down significantly the movement of food from the stomach to the small intestine. And this is absolutely correlated with SIBO and dysbiosis. And in fact, Terry and Joe, this is such a problem now that we have new guidelines in gastroenterology for patients having GI procedures as a result of the anesthesia complications, where we put the scope in and we have a stomach that's still full of food that should be empty because the motility is affected, and the food comes up and the patient aspirates it. It gets into the lungs. It can cause severe pneumonia. It can cause severe respiratory distress. So we've put our heads together with our anesthesia colleagues and had to come up with a whole brand new set of guidelines about what to do if you're on one of these drugs and having a procedure, because the safety is such a concern.
How have those guidelines changed? What should patients know?
They really need to, it depends on what procedure you're having and the indication. So there's not sort of a one-size-fit-all guideline I can give people, but it basically involves not eating for much longer before the procedure than we would typically recommend, and sometimes modifying the diet to make sure that the GI tract is indeed empty before we go putting a scope in there.
Well, I want to get very specific. How long does it take in a normal situation for food to get from your mouth out of your stomach?
Usually 90 minutes is typical, but it depends dramatically, Joe, on what you're eating. So for example, food with a higher fat content, the stomach empties much slower. Once those chemical receptors in the stomach sense fat, they send a message to something called a gastric pacemaker, which is a bundle of nerves in the stomach, and say, whoa, slow way down. We've got fat on board. It's more complicated to digest. It's going to take longer. And that actually slows down the contractility of the stomach. That's very different from a simple carbohydrate. Liquids versus solids, how thick, how viscous, etc. So the motility of the GI tract and how long it takes things to empty varies tremendously with the amount of food, the composition of the food, and also what else is going on in the GI tract. So if you have a very full colon and your colon hasn't emptied out, that can actually slow down the emptying of your stomach, because your colon sends a message to the stomach saying, whoa, don't bring any more food in here. We're still full down below, and that can affect motility. So it depends on some of these other things. But again, we're still sort of working out all the details, but trying to come up with new guidelines based on what the procedure is a person is having. Are they having a colonoscopy? Are they having an endoscopy? Because a colonoscopy, even though we're just putting the scope in the colon, that also has a risk of aspiration, because we do inflate the colon full of air. And that air that we put in has an effect on the upper GI tract as well.
But let's just imagine a situation where I'm going in for an endoscopy to make sure I don't have a stomach ulcer. Normally speaking, I would be told, stop eating how many hours before you're going to perform that procedure?
Usually we suggest to people or we ask people to be NPO, which means nothing per orum, nothing by mouth, from midnight the night before. Other guidelines say nothing by mouth for 6 hours before the procedure. So if you were having a procedure at 3 o'clock, it would be nothing after 9 a.m. So you would maybe be able to have a light breakfast, just something very light, not a sausage omelet or anything heavy like that, but something light. And so 6 hours is usually, because we don't just want the stomach to be empty. We want the products of digestion to have moved through the stomach and be pretty far down in the digestive tract. We don't want them just sort of lurking right below the stomach there where they can still come up as we put a lot of the air in. So usually 6 hours is sort of the number. Some places do a little more, some places do a little bit less. And of course, it depends on what other medications people are on. If somebody is on a narcotic.
What if I have Ozempic on board? How long should I stop eating before an endoscopy?
Yeah, it really depends on what the procedure is, Joe. I'm very hesitant to give an actual number because those numbers are still being worked out and they vary from center to center based on their experience. But let me just say longer.
And of course, there may be some variation from one person to another as well.
Absolutely.
I would like to talk about a different type of intervention, and that is one that's been we've been sort of hearing a little bit about it over the last maybe decade or decade and a half, and that is fecal transplant or microbiota transplant, which sounds a little snazzier. Can you tell us what this is and why it might be useful?
You're right that we have been hearing more about it in the last decade or so, but FMT, which stands for fecal microbiota transplant, as you pointed out, or affectionately known as a poo transplant or a stool transplant, have been done for a really long time in some forms of Chinese medicine. The landmark study in the US was sometime in the last around 20 years when they used FMT to treat resistant Clostridium difficile, which is a type of bacterial infection in the colon caused by the bacteria Clostridium difficile. And what they found was that the FMT, the stool transplant, was so much more effective than antibiotic therapy, which was up to that point the typical therapy, that they had to stop the study. They felt it wasn't ethical to continue because the FMT group showed such a tremendous advantage. And so that was a study published in the New England Journal of Medicine a couple of decades ago that gave us the information that FMT is a really, really effective therapy for refractory Clostridium difficile. It's not the first line therapy, but what I find really odd, and I suspect you will too, is that Clostridium difficile is often caused by antibiotics, overuse of antibiotics that reduce a healthy species in the gut and allow the Clostridium that's often already present to proliferate, kind of like a yeast infection. The idea that we treat that with antibiotics, so something that's caused by antibiotics, we treat it with more antibiotics. So it's not surprising when you really think about it that that is often not effective, or it temporarily suppresses a Clostridium difficile, but then it comes back. And so FMT uses a different approach. Instead of trying to suppress it with an antibiotic, it crowds it out by introducing really large volume of healthy bacteria, non-Clostridium difficile, to try and crowd it out and get it back down to a reasonable level where it's not causing clinical problems. And that has been found to be hugely effective.
Can these transplants be used for anything other than a C. diff infection?
Interestingly, Terry, you'd asked about neurodegenerative disorders. So looking at things like Parkinson's disease, autism spectrum disease, et cetera, disorder. And some of those are really promising. What we find is that if the FMT is done in isolation without a dietary change, not surprisingly, it's not effective. There have been FMT trials in two of the diseases I treat, ulcerative colitis and Crohn's disease. And again, sort of mixed results. But unfortunately, most of the studies don't look at two really important things: the diet, as well as the concept of a super pooper. So with other organ transplants, we know and we recognize that the health of the donor organ is very important. We haven't really applied that same logic to FMT. And what studies have shown is that if you get your stool transplant from a super pooper, meaning somebody who has really high quality, high richness of stool, that is going to work better. And so most of the stool banks where we get stool from, they do the basics. They exclude sexually transmitted diseases that can show up in stool, things like syphilis and HIV. They exclude foodborne illnesses. You don't want to transplant infected stool. They may exclude some autoimmune diseases, but they don't ask patients like, how often do you eat at McDonald's? How much salad do you eat every day? Do you take how many courses of antibiotics and proton pump inhibitors have you taken? Because these are the kinds of things that profoundly impact the quality of the stool. So that's the other problem, is that the studies aren't really uniform in terms of the quality of the stool transplants.
Dr. Chutkan, people are taking a much more active role in their own health these days. And one of the things that's coming online this summer is the OTC, the over-the-counter Dexcom Stelo Glucose Biosensor System. It's basically a CGM, a continuous glucose monitor. And I'm wondering what you think about that, the idea that people will be able to track how foods affect their blood sugar levels.
We know that CGM can be very helpful for people with diabetes, but I have not been compelled by the data that we currently have to suggest that people without diabetes use this. And in fact, I think it can be misleading because certain foods are supposed to spike, they lead to a spike in insulin or a glucose goes up, and that's normal if you eat a piece of fruit, for example. And I think some of the CGM suggests that, these foods are bad. And you take the fitness industry. We know with all the tracking apps that we have for steps and heart rate and telling us how well we're sleeping and how much we're working out, that people are less healthy. And so if we take a leaf out of that book, I know that I used to run with a watch, one of these satellite watches, I don't want to say the brand, that would tell me how fast I was running, how far I'd run, all of this stuff. And I'll tell you, it really hampered the enjoyment of running so much that I didn't want to go running because I didn't want to know how slow I was going. I didn't really care. What was important for me was that I was out there moving my body and sweating. And again, the data shows that the more we track, actually, the less healthy we are. And so we don't want to substitute tracking numbers and data consumption for actually doing the healthy thing, like eating more beans and greens. So it's a thumbs down for me for non-diabetics. I just also want to say I'm not an endocrinologist. I don't treat diabetes for a living. So this is sort of a lay opinion.
You're listening to Dr. Robynne Chutkan, board-certified gastroenterologist and faculty member at Georgetown University Hospital. She's the founder of the Digestive Center for Wellness, an integrative gastroenterology practice in Washington, D.C. Dr. Chutkan is the author of digestive health books, including The Microbiome Solution and The Antiviral Gut, tackling pathogens from the inside out.
After the break, we'll talk about the most common digestive complaints.
What's bloating and what can you do about it?
Some digestive problems could be traced to the medicine cabinet.
Of course, diet plays a role too. If you like beans for breakfast as we do, how can you avoid gas?
What should you know about preventing gastrointestinal cancers?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The American healthcare system is one of the most innovative in the world, but it's also riddled with complex challenges like access to affordable medications and communication barriers.
There's a better way, and that's the name of a healthcare and technology podcast brought to you by SureScripts.
In this podcast, you'll hear from today's most inspiring and innovative leaders in healthcare with in-depth and personal conversations on the industry's most pressing challenges and how we're navigating them.
There is indeed a better way in healthcare. Subscribe to the There's a Better Way podcast today on your favorite platform. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is made possible in part by CocoVia Dietary Supplements. CocoVia Cardio Health is offered in both convenient capsule and powder formats, with each serving containing 500 milligrams of cocoflavanols to support heart health. More information at cocovia.com.
Today, we're considering how the health of our digestive systems influences the health of other organs. What can we do to address our most common GI problems? Lots of people are concerned about bloating, but there are a lot of different definitions of what constitutes bloating. What can you do about it?
To find out how to keep our guts healthy, we're talking with Dr. Robynne Chutkan. She is a board-certified gastroenterologist and a faculty member at Georgetown University Hospital. Dr. Chutkan founded the Digestive Center for Wellness, an integrative gastroenterology practice located in Washington, D.C. Dr. Chutkan is the author of several digestive health books, including The Microbiome Solution and her most recent, The Antiviral Gut, Tackling Pathogens from the Inside Out.
Dr. Chutkan, when someone comes to see you, they may have been referred, and so you may have a specific group of patients with specific complaints. But in general, what are the most common gastrointestinal complaints that people have?
Bloating and bowel irregularity.
Now, I know you have written a book about bloating. Is there a quick summary of what people can do about bloating, and what is it in the first place?
So when we refer to bloating, the most important thing is to figure out what is the cause of your bloating. Is it the medicine cabinet? Is it something you're taking that could be affecting your gut motility? Is it a food intolerance that you're having? Is it something hormonal related to estrogen or your thyroid? Is it something structural like a fibroid lesion or scar tissue? There's so many different causes. So in order to effectively treat it, you have to figure out what's causing it.
What kinds of symptoms do people experience when they're complaining about bloating?
Just for a quick definition, when we talk about bloating, we're referring to abnormal distension of the abdomen with either liquid or gas or something solid. Most people think about bloating, they think about air, but you can also see bloating as a result of liquid. And some of those causes are pretty ominous, like ascites, which usually refers to accumulation of liquid in the abdomen as a result of a tumor or as a result of liver failure. And there's solid causes of bloating too. And again, some of those are a little bit sinister, like a tumor, but some of them are also benign. You have growths in the abdomen or in the female reproductive system or in the male reproductive system that can be benign. So a little bit of diagnosis is important. The other thing too is sometimes people think they're bloated, but what they're describing is belly fat. And so the way I like to help people figure it out is I tell them to take a tape measure and measure around their abdomen, right around the belly button in the morning, measure it again in the afternoon, and measure it again at night. If they're really bloated, there should be significant fluctuation there, at least a couple inches. If they have belly fat, that number isn't really going to change.
And what do people do for bloating?
Joe, it's a great question. And again, it depends on the cause. If you're bloated because you're lactose intolerant, you should think about cutting down on dairy. If you're bloated because of a motility disturbance from a drug you're taking, you might want to rethink the decision to take that drug. If you're bloated because you're constipated, which is a huge group of the patients I see, then we really need to work on the constipation. And that may be a combination of adding some fiber to your diet, maybe a little magnesium, maybe more liquid to wash it all through. So it's really, there's no one size fits all because there's so many different causes of bloating.
Well, I'm so glad you mentioned the medicine cabinet, Dr. Chutkan, because a lot of times people try so hard. Try to eat a well-balanced diet, get all those beans and greens that you keep talking about, but they can't overcome, for example, flatulence or constipation. And then you look in their medicine cabinet and they're taking medications. In the case of flatulence, it might be a stop smoking drug like Chantix, or an antidepressant like Effexor, or a drug for osteoporosis like Fosamax. And if they're constipated, it might be that they're taking an antidepressant, or it may be that they're taking an NSAID like celecoxib, or a blood pressure pill like diltiazem. And I don't think the prescribers often mention, oh, by the way, this medication may cause gas. You may, pardon the language, but you may be farting like crazy. And no matter how much you're careful about your diet, it could be your medicine, or that constipation. Yeah, it could be the blood pressure pill, and X-Lax won't solve the problem.
And of course, if we're talking about diet, we're talking beans and greens, and beans are notorious.
Those are both excellent points. And Joe and Terry, I really share your concerns about the medicine cabinet. And I fear we're plunging deeper into this era of a pill for every ill, because now the supplement manufacturing is so aggressive. And Terry, you're absolutely right about the beans, but I like to call that good gas versus a bad gas from something else. And this is one example where actually there is a solution in the medicine cabinet. I frequently will recommend Beano. It's a digestive enzyme that contains alpha-1 galactosidase, and that helps to break down the kind of fiber in beans that we can't break down on our own. It's called raffinose, and it's poorly digestible for humans because it's not really meant to be digested by us. It's meant to be digested by our gut bacteria.
We had an opportunity, Dr. Chutkan, to meet the inventor of two fascinating dietary supplements. Maybe that's not quite the right way to describe them, but he invented Lactaid and Beano. And he was actually quite a fascinating individual. He lived in New Jersey, and he grew up on a dairy farm. And for whatever reason, he thought, these two products would be very helpful. I have to admit, we often rely on Beano.
Well, Joe's favorite breakfast, and mine too, is refried beans. Which,
love it.
Yeah, how can you get a more substantial breakfast if you've got a big day ahead? But you do want to take care of things, so we take Beano with our breakfast.
But, there haven't been a lot of great studies on Beano, so we just rely on our own personal experience to say, yeah, this works. The only trouble is if we go out and somebody offers us a really healthy, delicious salad with beans or broccoli and some other, flatulent-like foods, maybe some cauliflower. If we didn't bring our Beano along, we often end up in trouble. How well does Beano really work?
Beano is pretty good. I will say, of those two inventions, and I had no idea the same person was responsible for both of them, I think Beano is really fantastic because aside from some usually sort of allergic type reactions like rashes, hives, itching, it has a pretty good side effect profile. I mean, we've been using it in the GI world for decades, and it allows you to continue to consume foods that we know are so incredibly good for you. My advice to you, if you go out and you don't have the Beano, eat it anyway, and then excuse yourself and go into the bathroom and let it rip. That's my advice. But Lactaid is a little bit different because dairy is really for baby cows. I mean, it's a little unnatural when you think about it for us as an adult to be suckling a postpartum cow, which is kind of what dairy is. And it's really delicious, of course, with ice cream and all these different things, cheeses and so on. But most adult humans, and of course this varies from country to country, there's some geographical and racial, ethnic differences in ability to tolerate dairy. But most adults will lose their ability to digest dairy well as they go from infancy to adulthood. And that's because we're really not meant to be eating dairy. And so I think a substance like a Lactaid that allows you to continue to ingest a substance that your body is sort of rejecting because it's lost the enzyme that's located along the brush border there in the digestive tract is a little bit different from helping you digest food that we know is doing you a lot of benefit. So I'm all thumbs up with Beano, but a little more thumbs down with Lactaid.
Let's switch gears for a moment and let's go back into the bathroom. A lot of people look at their stool and they worry if it floats or if it sinks, does that make any difference?
Well, I applaud everybody who is turning around and taking a look. It's a great idea. In fact, it's a must do. You have to, it's like reading tea leaves. You have to see the feedback that your GI tract is giving you. But I wouldn't pay a lot of attention to whether it floats or whether it sinks, because that has a lot to do with the air composition, how much air is in it. Except in one situation, we can see fatty, floating, frothy stool with some forms of pancreatic insufficiency, but the stool really looks different. I mean, it's usually got oil on it, like a sort of orangey, oily look. It's usually loose. And it's not just that it's floating, but it's oily. And usually those patients are also really having difficulty maintaining their weight. So they're having tremendous weight loss and diarrhea and this sort of oily, greasy stool. And that's just very different from, your stool is floating on top versus sinking to the bottom. So I wouldn't worry about that in the absence of those other symptoms.
So that sounds like those oily, greasy, frothy stools should get you into the doctor right quick.
Absolutely.
What about color?
Yes, color makes a difference. And color is usually related to diet, but we can see color affected by certain diseases. So most of the dark brown color we have is because of bile in the stool. So diseases that affect the production of bile in the liver or that block the bile ducts can lead to what's called an acholic stool, acholic, and that stool would be very pale. And usually the excess bile is getting dumped in the urine. So that's usually in conjunction with darker urine than normal and very lighter, pale, chalky stools. And that can suggest a problem with the bile ducts or with the liver. But most people who have pale stools, it's because they don't have enough dark leafy green vegetables. And so if you're eating kind of that brown and white diet, meat and potatoes, meat and rice, if you're not eating a lot of beans and greens, you're going to have a sort of less impressive pale or brown stool as opposed to that nice deep chocolatey stool. And if you're really doing great with the vegetables, when I do my green smoothie in the morning and my lentils and brown rice at night and my spinach, I have a little bit of green tinge stool in the morning, and that's really fantastic. And that's not a problem at all. That's a sign that I'm eating really massive amounts of vegetables.
Of course, there's one exception, and there was, in fact, a video, quite famous, a professor who reported that he had pale floating stool, and it turned out to be pancreatic cancer. Can you give us a quick overview?
Yes, and that's why, I talked about the acholic stool. That's usually a problem with the bile ducts or the liver, but it can also be the pancreas. And in that situation, usually there is a darkening of the urine that accompanies that. So, in any of these conditions where you're having weight loss, which would usually be the case with pancreatic cancer, sometimes it can be associated with new onset diabetes, but any change in bowel habits needs to be evaluated. And again, by change in bowel habits, I don't mean that sometimes your stool floats and sometimes it sinks, and that's how it's been for, your whole adult life. I mean, an acute change in bowel habits really should be evaluated.
Dr. Chutkan, people are all excited about a drug called metformin. It's been around for decades. It's the most widely prescribed drug for diabetes in the world. And yet now people are hopping on the metformin bandwagon in order to prolong life. At least they say it's an anti-aging drug. But one of the complications for people is not everyone, maybe just a small number, but it's GI tract complications. Can you tell us some of the side effects before everybody says, I want a prescription for metformin, so I'll live another 10 years?
Well, first of all, the data, the anti-aging data for metformin is really scant. I mean, it's a drug for diabetes. So if you can control your diabetes, that may allow you to live longer. But there's very little evidence that for the average person taking metformin is going to extend life. And there's a lot of evidence that it could have GI side effects. And the commonest are diarrhea, nausea, and gassiness, flatulence. But some people have constipation rather than diarrhea. Some people even have vomiting. There's abdominal discomfort. It can affect the appetite.
And one last question, and that is colon cancer prevention. What foods should we be eating to reduce our risk of colon cancer?
We know that a diet that's high in plant fiber, in unprocessed plant fiber, so fruits, vegetables, nuts, seeds, whole grains, is highly protective against colon cancer. And similarly, cutting down on red meat, ultra-processed food is also protective.
Dr. Robynne Chutkan, thank you so much for talking with us on the People's Pharmacy today.
Terry and Joe, it's always a pleasure. Thank you so much for the great public service you do with bringing the People's Pharmacy to us.
You've been listening to Dr. Robynne Chutkan. She's a board-certified gastroenterologist and a faculty member at Georgetown University Hospital. She's the founder of the Digestive Center for Wellness, an integrative gastroenterology practice located in Washington, D.C. Dr. Chutkan is the author of several digestive health books, including Gut Bliss, The Microbiome Solution, The Bloat Cure, and The Antiviral Gut, Tackling Pathogens from the Inside Out.
And you know, Terry, as we review what we learned from Dr. Chutkan today, the idea that the GI tract is the engine for the rest of the body, that it's the hub for all those nutrients that we have to absorb that are critical for our good health.
And it's really important to think about those nutrients and the food that provides nutrients. Americans often tend to rely on medications.
They do, and we love fast food, but the idea that we make so much more of our serotonin, that neurochemical, in our digestive tract than in the brain, that comes as a big shock to a lot of people. And dopamine's made there as well. The idea also, by the way, that cancer dysbiosis and the microbiome may be all related, and that we need a good bacterial balance to keep our digestive tracts healthy, not just because of our digestive tract, but also because of the rest of our system as well.
Well, I found it fascinating, the idea that Parkinson's disease begins actually in the gut.
Yeah, and that there are these cells that are demonstrative, like Lewy bodies, can be found in the digestive tract before there's a problem with Parkinson's disease. That is just so fascinating. Well, that's all the time we have. Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews. B.J. Liederman composed our theme music.
This show is a co-production of North Carolina Public Radio, WUNC, with the People's Pharmacy.
The People's Pharmacy is made possible in part by CocoVia Dietary Supplements. CocoVia Memory and Focus is a unique formula made with a blend of ingredients that work together to promote attention and support long-term memory. It supports 5 areas of brain performance. More information at cocovia.com.
Today's show is 1395. You can find it online at peoplespharmacy.com. That's also where you can share your comments about today's interview. You can also reach us through email if you wish, radio@peoplespharmacy.com.
Our interviews are available through your favorite podcast provider and now on YouTube. You'll find the podcast on our website on Monday morning.
At peoplespharmacy.com, you could sign up for our free online newsletter. Get the latest news about important health stories. When you subscribe, you also have regular access to information about our weekly podcast. You can find out ahead of time what topics we'll be covering.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.